Hope that will be helpful. If you have any questions or comments, don't hesitate. And we're a small group, so we can talk about it. But so I called this the most treatable addiction. Somewhat tongue-in-cheek, because anyone who knows chemical dependency problems knows that opiate addicts are difficult to treat. But we have more treatment options for this addiction than anything else, including alcohol. Opiate blockers are stronger than heroin and pain pills. And that's true both at a microscopic level. They stick onto opiate receptor sites more strongly than heroin and other opiates. And also in terms of treatment, treatment that includes opiate blocker therapies are much stronger and more successful. So these are statistics for opiate dependence in the United States. This is to follow. There's also chemical structure similarity between prescription opiates and heroin. We're going to talk about treatment and intranasal Narcan or naloxone. And I have that in my pocket, so I'll get that out so I don't forget that. So first of all, to look at the statistics here, in 2012, 2.1 million people in the US were addicted to prescription opiate pain relievers. And 467,000 addicted to heroin. So see the numbers really weigh toward prescription opiates. Unintentional overdose deaths have increased 4 times, 400% since 1999. And that's alarming. Children born addicted, neonatal abstinence syndrome, has increased by 300%. And that's just in a 9-year period of time. And in 2010, there were over 13,000 unintentional deaths from prescription opiates. And all other prescription drugs are only another 17%. So almost all of the prescription drug deaths were from opiates. This is really quite different. When I first started in psychiatry, the prescription drug deaths were all from sleeping pills and tricyclic antidepressants. So 5-fold increase in treatment admissions for prescription pain relievers in a 10-year period of time. So it's an explosion. There are a number of reasons for it. One of the big reasons is that doctors always historically undertreated pain, unless you count, in the old westerns where they give you a stick to bite down on or something, that was pain treatment. But doctors were inordinately afraid of getting someone addicted, and so they would undertreat pain. A lot of horror stories we all heard about, horrible cancer deaths, et cetera, et cetera. And sure, it's bad to die of any disease, but it's inexcusable that you leave someone writhing in pain without treatment if there is treatment available. Unfortunately, we went through this period of time in pain medicine where we were, sky's the limit. We were treating with unlimited amounts of prescription opiates and unbelievably high doses that patients, no matter how much they're getting, they still want more. I'm board certified in pain medicine, and I did that extra study because I wanted to find a way to try to treat these people. And literally 1 day's worth of the drugs that they take could easily kill 3 or 4 of us in this room. And that's just a standard Tuesday for them. They might not even feel that sedated. And if they are sedated and kind of out of it, they don't realize it. Just everyone else in their family realizes it. So that's part of the problem. because the number of prescriptions for opiates has increased by about 3 times in that 20-year period of time. There's just a lot more prescription opiates out there. High school kids will go into medicine cabinets and get their parents good stuff and abuse it. People that are selling houses, if you leave your pills in your bathroom when your realtor is showing off your house, people are going to hit your pills and take them. So that there needs to be an awareness that, you know, there's a big market for this stuff and high demand. And unfortunately, if you're a patient, say on Medi-Cal, but you're getting prescription pills that can be sold for thousands of dollars every month on the street, it's a big temptation to sell your pills or to take your poor grandma's pills. And you know, she might not know the difference, but she's going to be in a lot of pain. And most of these prescriptions are to treat moderate to severe pain. 100 million people suffer from chronic pain in this country. When I first read that, I thought, nah, that's not possible. But then I thought, you know, our population's getting older, baby boomers are all hitting their at least 50s, if not 60s and 70s. And, you know, I have chronic pain. Some days I don't, but most days I do. And so I think the older we get, the more likely we are to have it. The other thing is, a lot of people who have had cancer chemotherapy have chronic pain because of the nerve damage from the chemotherapy. There's neuropathic pain. Recurrent migraine headaches are part of chronic pain. And low back pain is the real big problem. And that's all that kind of combines to make us the biggest consumer globally of prescription opiates. Almost 100% of the world's consumption of hydrocodone, that's Vicodin. There's a couple other brand names, Norco. But almost all of it is consumed in the US, and 81% of Percocet. Which is oxycodone. So that's interesting, and those are the milder forms of pain meds that are used. About 5% of people 12 years old or over are abusing prescription pain pills. In other words, non-medical use. So 1 out of 20. The chemical structure of the prescription meds like OxyContin and heroin, you can see the ring structure there. That's the working part of the molecule. Very similar. And your brain reacts identically to them. The main difference is heroin is faster peaking, faster acting, and also quicker to leave your system. So it hits you more quickly in a rush and then leaves more quickly and leaves you in withdrawal. But OxyContin is a pretty short, oxycodone is a pretty short-acting medication. OxyContin is a slow-release formulation. But up until recently, all you had to do was bite down on it, chew it, and it was a fast release. So OxyContin could be defeated by a couple of sets of good teeth. Kind of a low-tech way to abuse the drug. And that's changed, and there's actually some statistics about the change in OxyContin. OxyContin was so popular, hillbilly heroin, etc. There were whole cottage industries in Florida and in Appalachia. New England, Maine, Vermont has huge numbers of prescription drug addiction and heroin problems. You know, places that just never had it before. I mean, they had maple sugar, you know, that was as bad as things got up there. But, so opiate meds can produce a sense of well-being and pleasure because these drugs affect the brain regions involved in reward. So our most primitive areas of our brain are devoted to survival. So what do you need for survival? You need to be able to get enough food to eat so you don't starve to death. You need to be able to find a suitable mate so you can pass your chromosomes on to the next generation. And both of those activities are involved in pleasure, at least on a good day. And what happens is the opiates just hijack that area, and people who become addicted to them can't really feel pleasure from normally pleasurable activities and can only feel pleasure from that drug. And that's the problem. Once the brain is hijacked to that very strong stimulus, the relatively weak stimulus that normally drives us, including basic survival, becomes secondary, and people will put their lives in danger on a regular basis, even though, you know, they have, I can't tell you how many times I've had an addict say, yeah, I've had 3 friends die. And, you know, the first time I heard that, I just said, are you crazy? When your friends died, wasn't that enough to get you to stop? And I stopped saying that when one guy said, no, man, I wanted to get some of the same stuff because I knew it was good. So then I realized, okay, I gotta take my middle-class mindset somewhere else. This is not working. And that's what happens. When someone overdoses, everyone wants to buy that brand of heroin. I guess you could fake some overdoses to drive sales. No, that's, please cut that from the video. But, with repeated administration of opiate drugs, either prescription or heroin, it blocks the formation of your own natural endorphins. So endogenous opiates get inhibited. Any drug that affects your brain does so by mimicking your natural brain chemistry. So antidepressants work on depression because they mimic the effect of our natural serotonin and enhance that effect. Opiates cause a sense of well-being and reduce pain by mimicking our own natural internal opiates, which are endorphins and couplins. And but with repeated administration of strong opiate drugs, your brain just stops making your natural stuff. And that's a simplified explanation for why you can't feel pleasure except with the drug. Your own natural pleasure system is just out of business, and you stop producing your natural chemicals. And it also is the reason why we feel withdrawal and discomfort when you stop using the opiates. If you don't have any of your natural endorphins anymore, then you have no natural means of controlling pain. So that little bit of back pain that I have now that I didn't think about until just a second would get a lot worse if I was going through opiate withdrawal. And of course, addicts that are in full-blown withdrawal, everything hurts. Their teeth hurt, their hair hurts, everything hurts. Then tolerance occurs when you need higher and higher doses to achieve the same effect. And part of that is because you don't produce your natural endorphins. Part of it is probably a survival mechanism. Your receptor sites are less sensitized because they're getting overdosed. In pain medicine, we talk about not exceeding that level that will develop tolerance, but patients always defeat that. Well, not always, but almost always, where they're having a tough day and they're feeling stressed, and that feels a lot like pain, and so they medicate it just in case it is pain. And opiate addicts do the same thing. I mean, if you go through withdrawal and you're sick, when you don't have enough, when you do have enough, you tend to use too much. The typical heroin addict, heroin would be a good drug if you could use it every 3 hours. Typical heroin addict uses about 4 or 5 times a day instead of 8 times a day. So how do you make up for that difference? By overdosing yourself, you can make it last more like 4 to 6 hours instead of just 3 hours. And that's why people die of overdoses so much. Now, with prescription drug deaths on the rise, it makes heroin overdose look like a minor problem compared to prescription drug overdose. When I was an emergency room physician, I never saw anyone overdose on opiate pain pills. I saw Valium overdoses, barbiturate overdoses, and I saw lots of heroin overdoses. Now, you know, the prescription drugs are much more of a problem. And the establishment of tolerance is because of the ability of the abused opiates to desensitize the brain's natural system, making it less responsive. So there's growing evidence that prescription drug addicts are shifting to heroin as prescription drugs become less available or harder to use. That same OxyContin that all you had to do was chew it to crush it, now it's crush proof. You can hit it with a hammer and it won't crush. If you hit it with a sledgehammer and crush it, it still cannot be quickly absorbed. So chewing, it's out of the question. And because of that, and this is really interesting stat coming up here. I don't know if you can read this, but this is the downward abuse of OxyContin, this line here, and an upward line in heroin, where other opiates stayed about the same. Heroin use went up as OxyContin use went down. And that's because you couldn't chew it anymore and get a rush. And it's a whack-a-mole problem. As soon as you push the problem down here, it's going to pop up there. You push that one down, another one's going to pop up somewhere else. And this is the problem with many solutions or, you know, fixes for drug addiction problems. Until you deal with the underlying addiction, you know, you can incarcerate millions of people, you can make all sorts of really logical changes like they do with OxyContin, but the problem is it's still going to be there. If someone's addicted, they'll find a way. And frankly, if we did away with all opiates tomorrow, we just see a surge in alcohol dependence. All of the heroin addicts that I've seen that stopped using heroin because they got tired of going to jail, they've all shifted to alcohol, unless they've gotten in recovery. I don't want to. But when I was working as a methadone, as a medical director of a methadone maintenance clinic, I was really discouraged because so many of my patients just did not want to hear about becoming drug-free. They just wanted their juice, their methadone. And it was frustrating for me because I didn't want to be just their pusher, you know, with a prescription pad. And but part of it was, you know, we didn't know how to offer them a better option than methadone, and we do have better choices now. Methadone works really well, by the way, but it's sedating, and it really would be ideal to use about every 12 hours, and methadone maintenance clinics only dose once a day. Because of the sedation, and there's somewhat of a high with it, and also you can use heroin right on top of it, most people in methadone clinics are still abusing drugs. And they do drug testing, and if they show positive for heroin, they don't prevent them from getting methadone because it's a harm reduction model. They just prevent them from getting take-homes. Somebody just told me the other day, Daryl, were you there? Somebody said outside a methadone clinic, people were getting methadone, holding it in their mouth, going outside, spitting it out and selling it.
Yeah, selling their saliva and their whole meal.
Well, the saliva, you know, was just a little bonus.
Yeah, Bobby was telling us that, yeah.
That's right. That's right. And so, you know, when there's a will, there's a way, and when the drug has hijacked your brain and turned all of your intelligence and willpower and creativity toward this end, you're going to find creative ways to deal with it. And the people that are selling their methadone, they're selling it so they can buy heroin, because heroin is a much better high. But anyway, treatment needs to address the biochemical changes in the brain. Now, partly, if we can hold on to people and keep them drug-free for a year, they will have biochemical changes that are very beneficial. Now, I don't know about you, but it's hard to hold on to someone and keep them drug-free for a year. If any of you have a spare bedroom, we could park them at your house, and yeah, they wouldn't be any trouble. But, so, you know, it's easier said than done. Now, we do actually have access to excellent sober living homes that not only provide, you know, a safe, non-drug using place for people to live, but also some structure and assistance to be able to stay clean and sober. But opiate addicts historically have done very poorly in every treatment setting. And, you know, I've said it myself. Daryl's heard me say it, you know, heroin addicts are just really, they're real trouble because they're not motivated. They're just not good patients. And you know, when I have more and better treatment options available to me, I realize, you know what, sometimes they're really good patients. I just didn't have good treatment for them. But when they first quit, they undergo withdrawal symptoms, which may be very severe. Old school addiction treatment programs will say you need to suffer on the floor so that you'll never want to do this again. And that really makes sense, except it doesn't work. Except for the fact that it doesn't work, it really makes sense. So you go through all this pain and diarrhea and nausea and vomiting, and just saying all those words, you know, is kind of gross, isn't it? Hypertension, tachycardia, seizures, very rare from opiate withdrawal. Usually it's from alcohol and benzodiazepine withdrawal. But the other stuff, and believe me, people that get locked up in jail, they're not ashamed of being arrested. They're dreading going through detox on the floor in the tank there. And so the reason it doesn't work is because after they go through that misery, you know, thinking 24/7, you know, I need a fix, I need a fix, I need a fix, that need is so strongly reinforced they never ever. So if you can actually make them more comfortable, sleep it off as much as possible, they come out of it not craving as intensely. And that actually makes a big difference, just treating them symptomatically. But medications that not only just treat the symptoms like, say, nausea and vomiting, but also ease craving, that makes a big difference. And this is where medications like methadone or Suboxone have really made a dramatic difference, and we're seeing much better results now. So being able to help people regain control of their lives is a big part of it. And it's just a picture of the medications. Methadone does come in pills, and those are usually used in pain control. The liquid form is what's used in methadone clinics, and 10 milligrams and 5 milliliters. And then the Suboxone either comes in pill form or this is a little film. And it's like, there some lozenges or whatever come in this little gel film stuff, but you put that under your tongue, it just turns to gel, it sticks to the back of your teeth, gets absorbed through the oral mucosa, the membranes of the mouth, and it takes about 5–10 minutes for that to absorb. And because it's a small molecule, it gets absorbed well. And this has made a huge difference in terms of people not relapsing, not leaving treatment, and maintaining abstinence after treatment. The reason is, well, let's see. Okay, so both methadone and Suboxone have gradual onset. In other words, it doesn't give you a rush. It's a gentle onset, and it has long duration, so it stabilizes behavior. I said methadone really should be dosed every 12 hours. Suboxone can be dosed every 24 hours and actually stays in your system with significant effectiveness for about 48 to 72 hours. And so that what that does is it keeps people from going into withdrawal in between doses. I've had patients who, you know, they're high-functioning people, they've got low back pain, they take their Percocet exactly as prescribed every 8 hours, and for 4 of those 8 hours, they are in misery because they've built up a tolerance to it. It only works for about 4 hours, and then the last 4 hours, they're watching the clock, getting ready for the next dose, and they don't realize that they have an addiction. And when I say that word, I mean that they've built up a tolerance and they're exhibiting withdrawal symptoms. Not that they're addicts or, you know, some derogatory term like that. It's just a physiological condition of that addiction. And so the problem with these short-acting medications is the withdrawal between doses. Xanax in the benzodiazepine world, same thing. It's very popular because you get high with it. It's short-acting, but it leads to addiction very strongly because it only works for an hour and a half, 2 hours, and then you go into withdrawal. So Subutex and Suboxone are much less tightly controlled than methadone because there's much lower abuse potential, and they're much less dangerous in overdose to adults. All of the overdose deaths with Subutex and Suboxone have been children. With the exceptions, there have been a few deaths from people that shot it up. But the Suboxone formulation has Narcan in it, so that if you shoot it up, it has an additional opiate blocker that keeps you from dying. But Subutex does not have Narcan in it. And so there are addicts that have taken this form and shot it up and died. But actually, it's not easy to do. And the reason is because the Subutex, buprenorphine is the generic name, is a partial opiate agonist. What that means is it has an opiate effect, but it's also an antagonist, a blocking effect. And so it blocks itself to some extent. So literally I could take 100 milligrams right now, and even though I'm opiate naive, it wouldn't kill me. I would probably sleep for a couple of days, but it wouldn't stop me from breathing because of the opiate blocking effect. And children die of it just because of their relative small body size. I don't know about you, but every time, I take medications in the morning, I'm not fully awake, by the way. And the blood pressure pills that I take are like that big. And I drop one on the floor. And then, of course, I'm thinking, I've got a 2.5-year-old granddaughter, so then I'm crawling around on the floor. And I don't know about your pills, my pills always roll underneath something. And so then I find it there with all the fuzz and stuff. But, I'm scared to death not to crawl around and find that stupid little pill because of the risk with children in the house. And with Suboxone, of course, dropping the pill, I'm sure it happens to them just like it happens to me. And that's where the risk is. And that's why I ask people, do you have children at home? The answer is yes. I don't prescribe the pills, I only prescribe the film. Film is very hard for adults to open. So, although 2-year-olds might be smarter, but actually once you learn the trick, it's not difficult, but unless you know the trick, you're not going to open it. You have to wait till you're 18 to figure it out. And so the film is much safer for that reason. And the other thing I like about it is you can cut it with scissors. And I have patients all the time. This is why I think it doesn't have a high addiction potential. My patients are always cutting their dose. I got to tell you, none of my Percocet patients cut their dose. Not if they've been on it for a long time. And my Suboxone patients are always saying, I cut it into eighths. And I'm saying, how do you do that? Do you have a magnifying glass? They just cut it into little tiny strips and put that in a little Ziploc bag. If you keep the humidity off it, it doesn't turn to gel. And you can use tiny little bits of it at a time. And people over the course of time generally reduce the dose on their own. And and in general, if it's very rare to see someone, my patients anyway, that have any sedation or side effects from it. But if they do, I simply cut the dose back. It's usually not a hardship for them. The internet is buzzing with 15-year-old boys saying it's really, really hard to get off Suboxone. And it's not. If you cut it back gradually, it's much easier to get off Suboxone than any other opiate that's made. But if you stop it cold turkey, you will go into withdrawal. So in spite of how effective methadone and buprenorphine medication treatments are, they're still grossly underutilized. And it's the same reason I think doctors undertreated pain. We undertreat addiction. And there's a real bias that, those drug addicts either need to suffer or they're going to try to use, they're going to abuse everything, et cetera, et cetera. But I think there's kind of a morality there that they should suffer. They've done bad things. They brought this on themselves. Now they should pay the price. Eye for an eye, tooth for a tooth. And except for the fact that we all pay the price. Public defenders pay the price in terms of heavy workload. Taxpayers pay the price in terms of all the expense of both prosecuting and defending people and housing people, which I think is running about $50,000 a year. And the only one that's doing well in this equation are the prison guards union, but everyone else is losing. And we have literally millions of people locked up because of crimes related to addiction. And if we had unlimited money and it was working for some good purpose, I'd say we're doing a great job. But we're running out of money, we're bankrupting ourselves. We can't afford to build more prisons. So, for this reason, I think we can't afford to incompletely treat this kind of opiate addiction. And, obviously, I might be preaching to the choir to some extent here, but I think we all come from the same culture that, well, drug addicts shouldn't be coddled, right? We shouldn't make it easy for them. But if you have the statistics that it's costing us more money, we can get, have better effect, reduce recidivism, reduce crime, both violent and property crime, by using these medications. I think it becomes pretty clear, and you can present a coherent argument when you're trying to explain it to someone. The idea that you substitute a new addiction for an old one, basically it's the same addiction. The difference with Suboxone, though, is that because it's a partial blocker, your natural endorphin system starts to come back alive. So you start making your own natural endorphins, even though you're getting the Suboxone. And that's a big difference. 9 out of 10 of my chronic pain patients has defined, well, my definition for my patients, they've been on high doses of opiates for more than a year. Typically, they had some horrible back surgery 5 years ago, and they really needed pain meds while they were going through physical therapy, and et cetera. But it's been 3 years now, and their opiate levels have escalated, but their pain keeps getting worse all the time. When I take them off of all these very powerful opiate meds, the ones I said would kill many of us, their pain is less. So I have them on this Suboxone. It's a partial opiate blocker. It's not sedating, and they have less pain. How do you explain that? The only explanation I can give you is that their natural endorphins are starting to come back online, and those work better than the artificial ones. And they had built up such a tolerance to the artificial ones, they weren't working anyway. They probably stopped working within 3 to 6 months after the acute pain stopped. And all they were doing was driving down further and further their natural pain relief system. So we actually we're not substituting a new addiction for an old one. We're treating it in a much more effective way. When I start people on Suboxone, I tell them, look, I don't want you to drive, if you're snowed, if you're dangerous to drive. I don't want you to be overly sedated, but I don't want you to be sick. And if you need to take this every 2 hours until you get relief, that's what I want you to do. If you get sleepy or if you feel some effects of it, then that's when you stop and call me, and then we'll calculate your total dose, and that'll be what you need on a typical day going forward. I don't say don't use too much of this stuff, because that's bad. I tell them, I don't know exactly what your dose is going to be. I can estimate pretty well, but if you need more than that, that's fine. I want you to get the dose that keeps you from craving and keeps you from relapsing back to what you were using. And that's true for heroin or Vicodin, either way. With Vicodin in general, the doses don't have to be as high. And if you don't give high enough dose, then that gives the perception that the drugs are ineffective. And it'd be like saying, hey, I took a half of an aspirin and it didn't work, so aspirin is a waste of time. If you don't take the right dose, it's not going to work. IN, that's a different one, or intranasal dosing of Narcan and naloxone. Naloxone's a generic name for Narcan. Narcan's a small molecule, it crosses the nasal mucosa easily, and it will work almost as well as IV Narcan. When I was an emergency room doctor, I had the screech beep beep type of admission to the emergency room, which I know you all know what that is. The screech was the tires as they slid to a stop outside the emergency room. The beep beep is when they hit the horn and they dumped their buddy on the sidewalk and took off. I guess maybe that was another screech. But so they bring in someone to me in the middle of the night, they'd be purple. And, you know, it was pretty clear what it was. And we get out the Narcan and have to start an IV, which was easy because they'd been using heroin for the last 10 years and all their veins were scarred up. I'm being sarcastic. It was not easy. Often we had to go jugular or femoral. Big veins here, you know, that would be my favorite spot because, you know, they're so big even I couldn't miss them. And push the Narcan in 1 second you have a guy who's not breathing, the next second you have somebody who's breathing well enough to cuss you out and tell you how you messed up a perfectly good high. And it's so dramatic. People refer to it as the Lazarus effect, where they literally rise up from the dead. And you know, I've had to try to push Narcan directly into the heart when I couldn't get it into the vein, but the only one time I tried that, it was too late. The person was dead. And with nasal Narcan, you save all the time that it takes to start the IV. And not only that, everyone in this room has probably used nose spray at some point. Was it Afrin, you know, decongestant spray? It's exactly as complicated as that. You squirt something up into the nose. The only complicated part, I guess, is when you draw it up with a syringe out of the vial. But and this is something that has gained widespread acceptance with first responders, police officers, EMTs, etc., and saved a lot of lives. In Massachusetts, they've been doing it for 9 years now. And there's a lot of good data that they've saved a lot of lives with this. Typically, it takes about 90 minutes to die from a heroin overdose. So even though you may pass out with a needle in your arm, you don't stop breathing immediately. You gradually slow down, build up carbon dioxide, get edema in the lungs, and takes, average is about, it's about 75 minutes, but 90 minutes, hour and a half is not unheard of. So it gives you time, if somebody finds you, to be able to save somebody's life. And a lot of parents have been desperately getting Narcan, you know, nasal spray to try to save their kids because their kids are still using heroin. But my problem with that and not getting them into a treatment program is, you know, how many kids use where their parents are, you know. Hey mom, I'm going to be slamming tonight, so just want to let you know. And besides that, you know, they don't use heroin in large amounts, usually at convenient times. And so the idea that you're going to stay up 24/7 and watch your teenager, you know, that's a dreary existence. So what I've said is, if you're concerned enough to buy nasal Narcan, you should be concerned enough to get your kid into a treatment program. And then of course the next reply is, well, but Junior says he doesn't want to go. And so then I say, well, how does Junior buy his heroin? I don't know. I give him $1,000 a month, but that's for incidentals. So, yeah, and I hear this all the time, and I've had people in treatment that were doing pretty well, and then they relapse, and how do they get the money? Well, they needed a haircut. And their haircuts are really expensive these days. So you know, that's, I guess, instead of blaming the family, I need to think of it in terms of, hey, the family has been programmed to keep providing the money, because otherwise, you know, their kid's gonna be really sick, or commit a crime, or some other calamity. And so either out of guilt or out of love, you know, they're providing the money for ongoing addiction. But anyway, you know, I don't have any problem with getting the nasal Narcan, but I think treatment needs to come first, and figuring out a way to cut off access to funds that somebody's still actively using has got to be part of treatment. And sometimes I'll have parents who'll go from one extreme, providing large amounts of cash, to the other extreme, I'm going to cut you off, I'm not going to give you anything, and I'm not going to pay for you to get treatment either. Which, you know, doesn't make a lot of sense. If their child is ready and willing to go into treatment, you know, I tell parents, you need to support that and a clean, sober place to live. Just don't provide any cash. One way to do that is to have a bank card that has a certain limit on it, so that it can just be used for small incidentals, but you can't withdraw cash with it. So pretty simple. But anyway, there's some stats here about comparing IV Narcan to nasal Narcan, and basically it works at about the same. It takes about the same amount of time for it to work. However, the paramedics like it better because you don't have to try to start an IV. So, you know, it's being used more and more, and I predict, here's a picture of how simple it is. And I sent off for my, this is an atomizer with a lure tip attachment. I sent off for that, and I paid a lot of money to have it delivered overnight, and they still didn't get it to me. So, but what this is this is just a regular syringe like this. That's got a needle on the end of it, so I can withdraw some water here. I didn't want to waste the good Narcan. But you just drop a couple of milliliters, which is that much, and I'm not doing this right. There you go. So a couple of milliliters. Should probably take the needle off because that'll hurt. But and you attach the atomizer tip. You can see it's a pretty large amount of volume. It's probably going to squirt up to the ceiling if I do it. But with the atomizer, it puts it in a spray that can be absorbed. There you go. Sorry, Sharon.
How you feel?
Yeah. Are you feeling withdrawal? And within minutes, people will start to come around, even from an overdose. It's not quite as abrupt as pushing it IV, but it takes about the same amount of time for people to be able to walk and talk and be more alert. So there's a couple of advantages, although they're probably still not happy when they wake up for being like this. And it's as simple as that. By the way, this part costs $4.95, and I'm sure it costs them 15 cents to make it. But so for less than $5, you can get the attachment. The Narcan itself costs about $30–40 per dose, and that price has gone way up since this has hit the news, etc. And this is a more concentrated form here. It's 1 milligram per milliliter, and it's a 2 milliliter vial. So there's a less concentrated form that's used for IV administration, but that would be, instead of this dose, it would be, what, 2.5 times that. So that's a large amount of fluid going down the back of someone's throat. They're not really conscious, you know, you want the more concentrated form. And, but that's as complicated as it is. It's not a big deal. And this study is really interesting. This is out of San Diego County, the drug court in Vista. So they did a study there. They had 19 people who were getting naltrexone. And we've been talking about Narcan, naloxone. Naltrexone is the longer acting opiate blocker. Narcan's very rapidly acting, good for emergency use, and not good for long-term blocking of opiate receptors. Naltrexone is available in a pill form. When it first came out, it was called Revia, and it was used to reduce alcohol craving. 50 milligram pill. And we also used it to reduce opiate craving. And in controlled studies, it works perfectly. Because in controlled studies, people get $5 every time they come in and get a dose. And probably a donut and some orange juice. And however, in real world studies, it doesn't work very well at all. Because no one's there to give them $5 and a donut. So they forget to take the pill, or they forget 3 days in a row and then say, oh, I can get high if I want to. And I don't know about you, but I'm a doctor and I forget to take pills. You know, regular people forget to take pills. It doesn't mean that, you know, they're trying to defeat the system or something. But if you forget it and then you have a resurgence of craving, then it doesn't work. So the pill form of naltrexone is a big failure in terms of controlling opiate dependence. It's more effective in controlling alcohol dependence, if you can believe it, because you have less craving for alcohol. But the same problem, if you forget to take it, the craving for alcohol can come right back. Now, Vivitrol is the injectable form of naltrexone. And it's microencapsulated, and I'm going to finish up here in a couple minutes because I want to hear from you and not just from me. It's the same material that absorbable sutures are made out of. So they encapsulate the medication. And it's a complicated process, and it has to be continually refrigerated at 50 degrees or less. Once it gets above 50 degrees, the capsules start to melt and it doesn't work anymore. So if you can imagine, you know, they have to manufacture it, bottle it, store it, ship it, all with controlled temperatures. And if it gets warm once, it's ruined, and it's pretty expensive. So that's part of what contributes a lot to the cost. The cost of the medication, see if I can do the math, is about $25 a day. So, which comes out to about $750 a month. And when you figure the societal cost of an active heroin addict, probably just in policing alone, it's got to be $25 a day. Because these are the frequent flyers that are always getting in trouble and getting violated and on probation and having to go back in. So, and this isn't $25 a day for the rest of their lives. Typically, treatment of 3 to 6 months is, well, I'll show you something about the statistics. And you can read it here. The group of people, and they have this broken down in 3 groups: people that got no Vivitrol, people that got at least 1 Vivitrol shot, and people that got all 6 shots. I think it's more helpful to talk about the people that got the 6 doses. None of the people who got 6 doses had positive drug tests for heroin, as opposed to 79% of the group that did not get Vivitrol. Now that's a really important statistic. None of the people who got the shots of Vivitrol had been rearrested within 18 months after the study started. So that was 6 months they were getting the drug, 12 months they were not getting the drug, but they still didn't get rearrested. And versus 30% and 6% of the group that did not get it. So big difference in recidivism, big difference in relapse of drug, which of course leads to the recidivism. Because, you know, unless your daddy's rich, if you have a heroin addiction, you're going to turn to some criminal activity, usually dealing or stealing to pay for it. And the big problem with that is, to finance your heroin habit, you need about 10 customers as a dealer. So that creates an exponential increase in the number of addicts, because as they get addicted, they need 10 customers. And it goes on and on like that. And likewise, if you can treat someone and they stop using, there's a possibility that 10 other people who would have been addicted will not be. And I keep hoping that with RecoveryWorks, when people get clean and sober in recovery, they'll tell 10 people, and that will kind of spread.